Awesome. Hi, everybody. Thank you so much for joining us this evening for our event, Beyond the Valve, taught by Rachel. I am so excited for this webinar. You probably already know Rachel, but if you don't, she is nationally and internationally known for her work with trach and vent patients. So this session is going to be absolutely fantastic. A couple of housekeeping items before we get started. This session is eligible for zero point 0.1 ASHA CEUs or 1 PDH. If you would like to obtain ASHA CEUs for attending this webinar, we ask that you stay for the entire duration of the event and that you complete a brief survey within 7 days of the event conclusion. So today's Tuesday, so by next Tuesday. And I'll put that survey link in the chat. If you're on your smartphone and you can't access it, no worries. It will be sent out via Zoom email after the course concludes. If you'd like a certificate of completion, please send us an email request at tims-univ@tims.com and please include your first and last name. And I will note that sometimes responses can take between 7 and 10 business days, so be patient with us, but we will do our absolute best to respond to you within 24 to 48 hours. And finally, if you have questions during the webinar, feel free to pop them in the chat or the Q&A. Rachel has allotted quite a bit of time at the end of this webinar to answer your questions. So with that, I'll hand over the floor to Rachel.
Perfect. Thank you. I'm going to get ready to share my screen. Okay. All right. Let me just make this bigger. Sorry, guys. There's a lot of things on my screen right now. Hold on. Down here. Okay, perfect. Here we go. All right. Hello, everyone. My name is Rachael Silveira, and this is Beyond the Valve. So we're going to talk a little bit about the SLP's role in building airway readiness across trach progression. Again, my name is Rachael Silveira, and I own a company called Trach Talks and SLP Badge Buddies, as well as a Global Tracheostomy Collaborative Committee member and a Tracheostomy Journal manuscript reviewer. So about myself, just figured I'd add a little bit. So on a personal level, I've been in acute care SLP for about 9 years with diverse training in dysphagia management, including trauma, burn, neuro, complex respiratory compromise, and a couple of years in NICU pediatrics. So actively, I'm working at about a 1,500 bed, soon to be, I think, 1,700 bed hospital, stroke, trauma, burn, and transplant in Miami, Florida, with focus on research-driven practice. I strive to continue educational endeavors, including exactly this, providing webinars, Zooms, guest lectures at different universities, different educational platforms. I've been a mentor to several ASHA STEP mentees and taken student clinicians in the hospital and curated trach talks and the badge system. And then kind of touching on this topic, we're going to go into tracheostomy initiatives and kind of airway readiness and how you can develop something like this in your hospital as well. My disclosures are prior honoraria for similar tracheostomy focused education and a monthly income from my businesses, and my non-financial is just participating in IRB research. So my name will be on some articles and we'll mention those today. So what are our objectives for tonight? I provide many different lectures that are going to be very data driven or very hard, concrete vent and trach learning, but this one's going to be a little bit broader in the sense of we're going to describe why tracheostomy progression is nonlinear and why tracheostomy teams are imperative for sustainable success. So oftentimes we think that it should be one step after the other, and I'm guilty of that as well. But as I've been practicing, and hopefully after this presentation, you guys will kind of understand that non-linear component and take it into your practice and have a better understanding to talk to your colleagues about tracheostomy progression. We're going to apply a readiness framework to interpret airway, swallow, and communication data. And with that being said, this is very SLP driven. So we will give some examples of intervention. And that includes things that you can implement tomorrow if your facility has these. So inline speaking valves, fees, MBS, EMST, capping, downsizing, and decannulation to support safe tracheostomy progression and decannulation planning. And then finally, we'll review a few slides about integrating our evidence-based practices and reducing variability in care to overall improve our functional outcomes across the airway, swallow, and voice continuum. So this is an image that I hope we can remember at the beginning and the end of the PowerPoint. But really, I want you to look at the left image, and that is the expected trach trajectory from an SLP's perspective. If you were to show this image, this left image to any doctor, they wouldn't really understand this trajectory, but they could probably identify some markers on here, like, oh, we placed the trach maybe 4 dials down, they want a speaking valve evaluation, and then they go all the way down to the bottom and they talk about decannulation. But they don't really understand a lot in the in between. But when speaking to a physician, speaking to a surgeon, speaking to a respiratory therapist, or even colleagues, that's sometimes the vision of the order that it should go in, right? But if we peer off to the right here, we kind of see what the reality is, and that's the dynamic airway readiness. So we SLPs are very imperative to airway readiness, right? And I'm trying to use my words correctly here without stepping out of our scope because we're not respiratory therapists, right? We're not surgeons. We're not the airway specialists like an ear, nose, and throat doctor or an ENT or otolaryngologist, but we are airway readiness and monitoring appropriate. So within this dynamic airway, you can see that those same subsets of speaking valve, fees, swallow assessment, diet advancement, capping, downsizing, vent, weaning, respiratory status, all those things are cylindrical, right? And they're not in a specific order because let's say you get the evaluation and your first stop on your rehab journey is to trial a PMV. And then you decide, so if I follow my mouse here, then you decide maybe you want to do a fees and a swallow assessment and advance their diet and work on capping and downsizing. But uh-oh, they had a surgery here and they got reintubation's not correct, but they needed to go back on the vent. Then that changes now to vent weaning, right? We can't immediately just jump back to a diet advancement if something went wrong and they had to go to surgery. Or maybe they're completely fine and they come back from surgery and they have a sedation change, right? I had one today that was scheduled for a fees and they had to give Seroquel. So that patient's now getting a sedation change. And then he went back on the vent. So our plan is constantly, the reality is it's changing. Respiratory status is a huge one, right? We go in with one plan to do an inline speaking valve and we find out that FiO2 is 70, 80, 90. Well, that respiratory status is not stable for us to work with. Is there something else that we might be able to do? Probably not a swallow assessment, probably not a speaking valve, but maybe some education or prepare for the next session, talk to family. But realistically, this image, the dynamic airway readiness, is kind of what we're normally seeing on an everyday basis. The left picture is what a perfect world would look like. We would get the trach, we'd get the consult, we would do our airway readiness assessment and our cuff deflation trial and decide if this patient's ready for a speaking valve. You know, your fees and MBS is more clinician dependent in which order you'd like to do that. Then you advance their diet and then prepare for decannulation by capping. So keep this image in mind, snap a shot of it on your phone, but kind of think about this when you're walking into a patient's room or when you're even having a conversation with the physician, because we often get tunnel vision and really only see our goals, and we forget that all these outliers, return to vent, acute infection, surgery, and sedation, are important and they affect our plan of care. So that's going to be the center of our conversation today. So that brings us to a trach team, something that I've been trying to do for many, many years at many different facilities. But this is the SLP hill that I will die on, is creating tracheostomy teams with speech involvement and speech heavy involvement, right? So we want to enhance airway readiness through multidisciplinary efforts. What are these multidisciplinary efforts? Trach teams, right? They're collaboratives, are learning communities that can drive positive change through effective communication, dissemination, and implementation of proven strategies. This is in 2018, right? Another article in 2013 showed that tracheostomy teams enhance the consistency of care through development and implementation of interprofessional protocols. We know that. We know that teams, whether it be rapid response team or a code blue team or your surgical team, your scrub tech team, they allow for more efficient and effective communication and decision-making collaboratives of diverse professionals with different specialties. So why not use this for a tracheostomy population, right? So let's dive in a little bit more to the purpose and why they're imperative. Why do we create a team? If you didn't know, aside from intubation, tracheostomies are the most frequently performed ICUs in the ICU, and this is not including like central lines, midlines, and like the typical routine exchanges. However, there's very little consensus in the post-operative management that has been identified. So we do them a lot, not we, the surgeons do them a lot, but then there seems to be no consensus on what we do after the fact. So it's so quick, it's a trick, but what about the management after? The lack of standardization in this complex population can result in both short-term and long-term complications. So some of these complications can be, and you probably are thinking of these right off the top of your head, bleeding, right? Risk of infection, tube blockages, return to vents, aspiration pneumonias, death is a big one, right? That's a long-term complication of a tracheostomy. Short-term would be more of the bacterial infections or ventilator-acquired infections, a mucus plug, a tube blockage, a bleeding event. Those bleeding events happen quite often. So many of these complications can be prevented with standardized management by a specialized and experienced team. And then if we move past just complications, we look at inconsistencies in care, right? The trach is placed, we're trying to avoid complications, but let's also continue the care that's being provided in both ICU to then step down and so on and so forth. The care is variable from follow-up to premature transfer out of ICU or just general lack in standardization. What are these inconsistencies that we're talking about? Choice and sizing of tubes. So you have like a champion surgeon on your team that's going to help differentiate when we should be putting an 8 cuff versus a 6 cuff based on the size and the gender of the patient. The initial tube change, right? Are we doing 7 days? Are we doing 10 days? Are we doing 30 days? It's very, very dependent on your surgeon and on your team. Who's managing the cuff? Is it respiratory therapist? Is it the surgeon? Is it the resident? Is it a fellow that's walking down the hall? Decannulation and capping protocols, inconsistencies in the timing of our speech evaluations. That's us, right? And I bet you're kind of thinking along in your head right now, oh yeah, that consult that I got, you know, 2 months after that patient got a trach, that's a big inconsistency in care. I mean, unless you're hospital, that's their common practice to consult you 2 months later. But really, that's a delay in care and very unfortunate for the patient, right? They suffer the consequence. And then finally, some inconsistencies are noted in how emergency procedures are done. So an accidental decannulation or a blockage of a tube, care and cleaning, and who provides the patient family education. So, moving a little bit more into our speech realm, why is a trach team important aside from complications, aside from short and long-term complications and inconsistencies in care? What are the direct effects associated with speech? So we know speech and swallowing. We know that there's communication deficits. We know that there's redirected air from away from the vocal folds, right? There's also dysphagia. So we live at speech therapists, we live at the intersection between airflow, swallow, and communication. All the deficits that are associated or direct effects associated with tracheostomies are speech pathologist realm, right? From the altered swallow and breath coordination, subglottic or reduced and absent pressures, potential reduction in sensation when a patient aspirates, and the comorbidities that go along with dysphagia, right? Weight loss, xerostomia, etc. Overall communication limitations and dysphagia can impact our patients' direct quality of life. It can affect their ability to participate in outpatient, occupational therapy, physical therapy, all the modalities in the hospital can affect their mood, their quality of life, and then all therefore keeping them in the hospital longer. Right? So we as speech therapists can assist in restoring voice and swallow, which can improve the patient's experience and their quality of life. Think about how important it is for communication and how it's a shared decision-making process in a hospital. So when I go into a room or I read a note, and for example, palliative care is saying patient unable to communicate, patient nonverbal. That's a huge red flag in my book because that patient is verbal. We just got to put a speaking valve on them, right? In some cases, they're not verbal, right? But in a patient that actually is, we just have to use the right resources and advocate by utilizing a tracheostomy team or dedicated professionals to aim towards assisting that patient to get their wants and needs addressed with that palliative doctor who's probably asking them very, very high stake, important questions about their medical situation. Okay. So something else that I take into consideration with a tracheostomy early in my career, I felt that the tracheostomy was the root cause for everything. Oh, they have a trach and that's why they have dysphagia. Oh, they have a trach and that's why they can't do X, Y, and Z. But in an article by Francis D. Gelberd in 2016, I think it's called like tracheostomy myths, or I don't remember the exact name. But basically, they showed that there's insufficient evidence that a tracheostomy itself is the cause for dysphagia, right? But rather it's a surrogate, which I love that word, it's a surrogate for the recent prolonged intubation that either led to the tracheostomy and or the patient's severe medical comorbidities. So when walking into a tracheostomy population's room or an evaluation, stop to think like it may not just be the trach that's causing it, but everything else. And I know a lot of you guys think that way when you go in to do an evaluation, but I am guilty of early in my career blaming everything on the trach. But then you have those patients who have a trach and do excellent, and you wonder, well, what's going on here? Like they had a trach, I thought their swallowing was going to be bad, right? So looking at everything, the whole picture. Instead of focusing on the trach as the cause, more attention needs to be paid to the etiology and pathophysiological function of that post-extubation dysphagia and how the global weakness or their comorbidities combined are affecting swallowing and speech and communication. So, again, that hill that we're going to die on is that speech pathology services are severely underutilized in tracheostomy rehabilitation. And that was an article by Davis et al. In 2021. When relying on consults from other services, speech language pathologists are less frequently involved if their participation was actually integrated into a standardized post tracheostomy care plan. The complex relationship between respiration, swallowing, and communications dictate that SLPs play an integral role as a part of a multidisciplinary team in the management of patients with a tracheostomy. Point blank, mic drop. We are very, very integral, and we should have a seat at that table because we work on all the way from insertion, right? When they get it, where we're immediately working on restoring voice or communication or modality for speech. We're immediately trying to attempt any kind of swallowing, Fraser-free rotor protocol, ice chips, an assessment, oral care, all the way to decannulation. So what can we do? This is repetitive because I know you guys know this, but just to reiterate, we can provide services to both ventilated and non-ventilated patients. We can provide instrumental swallow studies. We can assess upper airway patency and secretion management, which we'll review in a bit. Tracheostomy and speaking valve troubleshooting, downsizing and capping and decannulation, patient and caregiver and staff education, patient advocacy, and facilitating communications amongst us all. So when you look at why we belong, SLPs are underrated and sometimes missed. But when you identify readiness indicators for when the patient is ready or when speech should be on board, we can flag these barriers earlier by incorporating speech. We can provide objective data to both our counterparts, our ICU doctors, our surgeons, our doctors. We can provide input on what we saw on a FEES, what we saw on an MBS. We can advocate for a stepwise progression system. We can have a seat at that table, and we can reduce stalled trach trajectories. So, if the patient's going to get shipped off with a trach and we're like, well, I did a FEES on him and his airway looks pretty good. He's eating really well. We've tolerated a downsize. He's tolerating a speaking valve. Maybe we can try a capping trial. So these are things that otherwise, if you didn't mention, sometimes might go missed, and that patient is the one who suffers. So from data to decision, right? We're now going to apply we know our role, right? We know what a tracheostomy team is. We know why it's beneficial. We know why speech should be on board. But now we're going to apply that clinical readiness or that judgment for readiness. Now, what kind of readiness? Airway, swallow, and communication, right? But it's important to think, and this kind of shifted my mindset a little bit. Readiness is not determined by patterns across domains, but it's not a single successive task. So let's say it again. Readiness is determined by patterns across domains, not a single successive task. So what kind of drives me up a wall is when, and I mean, we're all guilty of it, but saying like, oh, patient didn't tolerate speaking valve. Yeah, done, out the door, bye, adios. Patient's not a decannulation candidate. See it a lot. I see it a lot on physician notes, which I don't know why they're the first ones placing the valve. I've seen it on colleagues, like other speech therapist notes from outside facilities. I've heard it from patients. Oh, they put the speaking valve on me once and told me I couldn't tolerate it, so we didn't put it back on again. We want to see how they do in domains across, like in their pattern across different domains, multiple visits. Okay, they didn't tolerate it on this date. Let's try it again. Or maybe we need to get a FEES and assess the airway and see why they're not tolerating it. Maybe we need to dig a little bit deeper, ask the specific questions to find out what's going on. So there's three interdependent domains, sorry, it's late for me, that I look at when I'm doing speech, swallow, or any kind of trach assessment. I'm looking at airway readiness, I'm looking at swallow readiness, and I'm looking at communication readiness. Now, this might sound repetitive, like, oh yeah, I already do this. But when you really think about it, like, are you doing this, right? So we're doing a swallow evaluation. Yes, that fits under swallow readiness. But are we just giving a PO trial and saying, oh, you coughed, not ready? Are we going straight to an instrumental? Are we assessing from the instrumental? Oh, you aspirated? You can't have that. Are we problem solving, right? So we want to look at these three interdependent domains and see how they all fit together across patterns to see how they're doing and are they ready for the next steps within these domains. I don't know why those question marks are there. Sorry. So our SLP contribution. So we are using airway, swallow, and communication readiness. So these are the things we're going to go over today. And a lot of this is common knowledge, but where does it fit? So then you can start incorporating this into your note writing. You can incorporate this into, at least when I speak to doctors and or physicians at rounds, I will use this terminology. I did X, Y, and Z, and the patient's showing a good prognostic indicator for good swallow readiness, good airway readiness. And they're like, oh, that's interesting. Like just when you speak it, you sound like you have a seat at the table, right? So we're going to talk about the tracheostomy post-op order sets, utilizing inline speaking valve early intervention, doing MBSs and fees for dysphagia management, also secretion management, respiratory muscle strength trainers, utilizing standardized capping and decannulation protocols, and also utilizing fees if you have it available for tracheostomy decannulation protocols as well. So let's dive in first to the post-operative tracheostomy set. So this is something that I've been kind of advocating for since I've started becoming, since I become an SLP, is that if you look at this post-operative set here from one of my old hospitals, speech language pathology evaluation and treatment is automatically checked, right? In my newer hospital, this was a surgical tracheostomy post-op set, order set. I don't have a picture of what the order set looked like underneath. It was very massive, but again, speech language pathology was pre-checked, right? So, in a recent study by Ma in 2017, about 10 years, number of speech language pathologists consults significantly increased compared to baseline after this post-tracheostomy bundle or order set was incorporated. The time to speech evaluation significantly decreased with the post-tracheostomy care bundle compared to baseline, right? So standard trach order sets or just standard order sets in general are not new to the world. They're not new to the medical field, but they have been shown to reduce length of stay in their specific facet, reduce mortality, and reduce medication errors. So we want a order set to include pre-selected speech consults, be clear, and have descriptive language and what they want. So we actually embedded into our post-op order set also speaking valve. So we don't need to run and get another order for a speaking valve. It's already embedded in our post-op order set. Now that came with the caveat that our physicians understand that we're still going to educate and we're still going to inquire, we're still going to ask the right questions and not place a valve on a not appropriate patient, right? Patient needs to be hemodynamically stable. Just because we have an order and yeah, we can do speaking valve, we're not going to just fly in there and put the patient in harm. So that was kind of an understanding like, hey, if we're putting this in the order and it's pre-checked, please like still come and let us know your plan. And that's fair. I think you go into rounds and you tell them what you're going to do. And they may say, like, no, not today. Today's not a good day. But you already had that order placed and good to go. Check the next day. So post-operative order sets are going to be game changers for getting speech on board and for also ensuring that the trach patient's getting all the necessary consultations and visits that they need. Early intervention and use of inline speaking valve. So in this picture, I have both the purple and the green. My last facility only had the purple, and then we had to advocate for the green, which, if you're not familiar, the green is the inline, and next to it is the adapter. So the green can actually, a teal, can be used both inline and on just like a trach hub, where the purple cannot because it has a lip on it. So if your hospital is really only willing to purchase one, I would say go with the teal because you can use it for both options. Okay. So advocating for earlier speaking valve use for tracheostomy patients suggests that speaking valves may positively impact swallowing, which we know, and rehabilitation. Current empirical research demonstrates that the use of a speaking valve in line with mechanical ventilation promotes self-ventilation and promotes independent ventilation and possible faster vent weaning, among many other benefits. That's a hard topic to bring up with physicians and surgeons and pulmonologists specifically because they want the evidence of how it's going to improve the weaning, and I don't have that information for them. But according to Carmona in 2015 and Sutt in 2016, there is literature, empirical literature supporting that a speaking valve in line helps with patients' own ventilation, independent ventilation, not respiration, but ventilation, and faster weaning. So it's something to advocate, it's something to talk about. It kind of makes sense if you're decreasing a PEEP on a patient, you're working their own lungs, you're making their own alveoli open and close and deflate and inflate. You're trying to improve the independence of the patient so that they could be then therefore removed from the vent. It does make sense, but I don't know the exact literature associated with it. So these are our first two steps in our airway and our swallow readiness. Now, if you had to think about where these fit under, a postoperative tracheostomy order set can fit under all three. It can apply to swallow readiness, it can apply to airway readiness, and it can apply to communication readiness. And then early intervention of an inline can also apply to airway readiness, swallow readiness, and communication, because what does it do? It improves airway patency, it improves communication, and it improves swallowing. So we've hit a bunch of domains with just these two options. So now if we move to fees and MBS for dysphagia assessment, we already know as speech language pathologists that bedside nursing and dysphagia screenings are not reliable at detecting aspiration. So sensitivity and specificity of these tests ranges from 45 to 80% and 62 to 100 based on different literature. That's very wide. That's very big ranges. I don't like those numbers. For a screen to only tell me 45% accurate, 80 is not terrible, but there's a big range in between. So we want to use instrumentation, right? So utilizing instrumental assessments for evaluation of swallowing post-tracheostomy is warranted due to the complexity of this patient population and the high rates of aspiration, specifically silent. So that was written by Skorts in 2020. That's very recent literature. An article from 1994, Alpern, showed that patients with tracheostomies and mechanically ventilated, amongst other medical comorbidities, are at high risk of aspiration, with up to 87% showing aspiration and 83 being silent. So that's an old study, and that was showing aspiration at that point. So we've only come so far in the last 30 years that it's still happening, right? So these patients are at high risk because of their underlying medical conditions. Also, their tracheostomy can cause an effect. It's important to understand that it may not just be the trach, but when you're expressing the need for an instrumental assessment to assess for swallow readiness, right? We're in that swallow readiness domain. We want to let them know that there's a high incidence of aspiration. There's a high incidence of silent aspiration. So we know that MBSs are known as a gold standard for swallow studies, but also there could be a platinum standard, which was identified by Teresa Richards for MBS and fees to detect at the same time or detect in different views, right? A lateral view or an aerial view. But a golden nugget is that fees has repeatedly demonstrated sensitivity equal or greater to an MBS in determining whether a patient is exhibiting penetration, aspiration, delay in swallow initiation, pharyngeal secretions that sometimes cannot be detected on an MBS. So sometimes it's better to just have both, all right? So using instrumentals, fees, and MBSs will help us understand that swallow domain. So when writing in our notes, we are working on swallow domain, and this is what we're using, instrumental swallow studies. So we also can use respiratory muscle strength training and utilization of capping and decannulation protocols. These two don't go together. I just put them on the same slide. But we know that RMST, or respiratory muscle strength training, whether it's EMST or IMST, the light or the full version, can fit under airway and swallow readiness, right? Because it can help with lung support and helping with that cough strength that's going to help us reduce aspiration or expectorate whatever is entering the airway. And it can help with swallow readiness by improving the swallow. The benefits include improved respiratory support, improved cough strength, like we said, a protective cough or an airway clearance cough. It can improve ventilator weaning. So in our hospital, especially on our lung transplant floor, our therapist is doing this in line with the ventilator. She's wonderful. Anna does it on all her patients. So they get the benefit of inspiratory and expiratory muscle straining while on vent. It promotes the use of diaphragmatic breathing and improves blood flow. We can also use it for vent weaning by improving lung volumes, which can support swallowing. It can improve vocal cord opening if you have like a paralysis, and it can assist in the overall weaning by liberating that patient and using their own breath support. Interestingly enough, the EMST for secretion management can help, and it's been shown to improve cough strength. So this is like a golden nugget to utilize in your facility. If you can't use or get all of these modalities, implementing EMST, RMST, IMST is really a lot of good bang for your buck because you're going to improve a lot of modalities with just one tool. Okay. You can use it in neurological populations that also have trachs, right? Like, if you're a Parkinson's patient with a trach or a really complex stroke with a trach, that if they're able to participate in therapy and even give you the simplest of like 5 centimeters of water, a single puff or below, you're working on something. Okay. Now, moving to capping and decannulation, because this is a huge one. This is where a lot of patients fall off, right? So this one's going to fit under airway readiness, right? Because I mean, it can help with communication, but really this one is big. And this is the one that sometimes I feel like a lot of speech therapists feel like we don't belong and we stop and, oh, the patient's tolerating a regular diet. They're tolerating their speaking valve. There's no other use for me on the case. And I beg you, like, please don't sign off this patient because like they need you. A lot of these physicians, a lot of these residents that are learning and they're learning from the older generation physicians, they are just told, oh, the patient can stay with the trach, they can go home and they'll come outpatient to get decannulated. Well, they're in the hospital, they're in a controlled setting. Let's evaluate them. Let's use a stepwise system and use something that's standardized, that's been shown in practice to be efficient, and see if we can get the trach out before they go home. Okay. So utilizing a standardized system on the right image, so not the left, the right image first, is a study from Pandian et al., who's Hallmark, she's a nurse. Well, now she's a researcher, but look up her work, Pandian, Pandian. She wrote this protocol on utilizing standardization for tracheostomy capping and decannulation. And they only assess 50 patients, so it is a small sample size. So 50 were decannulated. 45 of these patients met the criteria of this screening tool that we use right here in this picture. It had 90% sensitivity for identifying which patients could be decannulated and 100% for who could not. So this is great because it's telling you who cannot be decannulated, so don't move forward with it. And then 90% sensitivity for those who could. The positive predictive value was 100%, and the negative predictive value was 16.7. And if you look at the image to the left, very similar. It looks at clinical stability. It looks at airway endoscopy. Are they tolerating a speaking valve? Do you need an ENT to come and assess for upper airway patency? Is there something else going on with like secretion management? Are they able to cough? Like, so it looks at multiple modalities that we also assess when we look at a patient. So it kind of lines up really well with our assessments. But this was done in China. It was a multidisciplinary trach team in China who they utilized this decannulation protocol. And they had 115 patients that were evaluated, and about 56 were decannulated successfully. So about less than half, but I think that the one on the left needs a little bit more work and a little bit more follow up and what's the word, like checks and balances, where if you look at the protocol on the right, it does have a lot of systems in place where you have an authorized provider, you have a respiratory therapist, you have an SLP, and you have multiple people working through the flow so that you don't have a mishap. There's always going to be someone to check and balance your system. So as we move on to, how are we doing on time? Good. Standardized endoscopic swallowing evaluation for tracheostomy and decannulation. So this can fit under all three, right? So we're looking at both swallow readiness because this assessment actually assessed for swallowing. We're assessing airway for decannulation. And guess what? When you decannulate a person or a patient, their communication improves, right? Their vocal quality improves. So it fits under all three domains. So there's like a little bit of research on this. I only put 2 articles, but there is a third. So the value of endoscopic evaluation in airways and swallowing and tracheostomy decannulation. So you can see if these patients were unfit or fit for decannulation, if they received an endoscopic evaluation, and then their final status after adding the assessment. So what I found really cool about this study was that in the 2020 study, Bedside assessments for decannulations were done on 112 patients, okay? And 18 of these patients were determined to be decannulated. Now that sounds kind of crazy. Out of 112, why were only 18? Okay, moot point. We don't know why. However, the rest were not. For some reason, they were not. However, after endoscopic evaluation of the larynx, subglottis, and trachea that were performed on 59 of the non-candidates, another 13 of those 59 were then changed to decannulation candidates. I guess, wonder why, right? Because we're not just blindly looking at this patient from the bedside and saying, oh, yeah, they're tolerating their speaking valve. I think they're a decannulation candidate. Or how some of our physicians just put their finger over their trach. Oh, the finger occlusion worked. I think they're ready to be canned. No, you're getting direct imaging, right? So an MBS can show you a certain amount of, secretion clearance, residue clearance, sorry, excuse me, but you're not getting that aerial view. We're seeing from top down. We're looking straight down at the larynx. Do we see granulation tissue? Is there something obstructing the airway? How's their secretions? Are they having volitional swallows? So if you look at this image to the right, that's what it assesses. It assesses secretion, spontaneous swallows, laryngeal sensitivity, and cough. So the famous Eric Blicker introduced me to this protocol, and I've used it ever since. And when I show it to physicians and even surgeons, I say, look what the main findings, look what I looked at when I was looking at the airway. I wasn't just assessing for swallowing because I probably have already done a fees on this patient and put them on a diet. This is specifically like a decannulation fees. Or maybe I did them at the same time, who knows? But I'm looking at the things that they want to know. They want to know, is there massive pooling of secretions? Is this patient able to swallow multiple times while I'm in their airway, or swallow multiple times at the bedside when no one's looking at them? Are they able to protect their airway? Do they have a cough? Do they have a reaction when you touch their arytenoid or any posterior pharyngeal area of the wall? What are they doing? So once I start telling them these parameters, they're like, oh wow, oh wow. So the one thing that this is missing is what we call a tracheoscopy. So when they go in and up. So we're not getting that bottom view up where we would normally see like a stenosis or any kind of collapse of the trachea. That is out of our scope. So a lot of these or both of these will say there's like a tab or a section that says if there's concerns for airway stenosis, like for example, the patient's just not tolerating capping for some reason, and you did a fees and everything looks great from the top. There is a little bit of one liner. I don't exactly remember what it says, but it's like warranting an ENT consult. And we do that a lot. If we're in doubt, always get ENT to come check. They're going to do their above scope. They're going to look at the same stuff that we saw, but they're also going to enter the trach. They're going to go down and they're going to go up, and they're going to really examine that trachea for what we can't assess, right? But this one on the bottom right, Mule et al., did show that this tool to be safe and efficient to evaluate for readiness for decannulation in our patients, specifically the neurological patients, right? So that image is specific to the neuro patients. And those are the ones that are sitting in the bed with a TBI or maybe even a Ranchos 3 or 4, I'm not sure what level they might be, and no one will decannulate them because they're scared. And they're scared because the patient's not talking, the patient's not eating, right? But you don't need to be eating or talking to be decannulated. That patient had a trach placed for airway protection or for secretion management or pulmonary toiling, or maybe they needed to be vented for respiration and ventilation, but that might have been 2, 3 months ago. And that patient's sitting on room air, comfortable, maybe has a cough, maybe a weak cough, but has a cough, minimal secretion requirement, no suctioning. They're not even suctioning Q6 anymore. Let's do a fees. Let's see what it looks like. I have recommended decannulation on so many severe TBIs, and those patients are better for it. The families are better for it because a lot of these patients can't go to rehab, don't have benefits, don't have insurance, and they go home. And wouldn't you want them to go home without a trach versus with a trach and causing a whole slew of problems of infections and then teaching family how to suction? Then they come back because they run out of trach supplies. So I like to think about those things, airway, swallow, and communication readiness when I'm preparing for decannulation fees. How is this going to help my patient? How is this going to help the family member? Okay. So the results of this neurological patient assessment was 100 tracheostomy patients with acute neurological diseases participated. Following this protocol fees, the tracheostomy tube was successfully removed in 54 of the patients. So about more than half, okay? 29, only 29 would have been decannulated if using just a swallow assessment. So that's what they had found, is that this in-depth use of a fees added to more decannulation candidates. I love this tool. Amazing. Just try it out on a trach patient, see how it goes, talk to your team. You may be very surprised at how receptive they are to this result. So finally, as we wrap up all of our tools to determine patient swallow communication and airway readiness, right? These things that we are already doing in our practice. We want to shift from individual expertise to system reliability. So that's a huge thing in your hospital. You may work with 20 SLPs, but only maybe 5 are competent with trachs, or only 3 really give it your all. And that's the problem. So it really will depend. That trachs patient's trajectory for that day, for that week, may only depend on who's working that day. So you want to change and improve system reliability, because what happens if there's variability in the care that we provide, it will delay the speaking valve, which therefore delays that patient's ability to communicate and express their wants and needs or participate in complex medical decisions. It will lead to inconsistent NPO status. So one SLP might recommend NPO and then not do a fees, and the other one was like, why didn't you do the fees? So we want to remove that inconsistency. It can stall decannulation. They're not ready to be decannulated. Why? Oh, I don't know, because they're not tolerating the speaking valve. So there's another inconsistency. And then communication neglect. So integrating these evidence-based tracheostomy team practices and this airway swallow communication domain readiness can reduce your variability in care and can improve functional outcomes across the swallow, airway, and voice continuum. So we're still shifting. We're incorporating our standardized readiness criteria. We're creating clear criterias for our speaking valve use, our fees, our capping protocol, sit down, create flow sheets. It sounds like a lot of work, but it's a lot of work right now for success down the line. You're making clear readiness criteria that your team will all utilize. And I urge you to include the physicians, include the surgeons in your decision-making process, in your flow sheet creation, because you're going to get valuable information from them and buy-in from them. They're not going to agree with your criteria for fees or a speaking valve if they're not on board, right? Oh, don't put a speaking valve on my patient who has an FiO2 of 70. You need to sit down with them and talk to them about your criteria. You want to structure multidisciplinary rounds. This one's huge. So get in there, start talking to the doctors, find your champion, find someone who you really get along with and use them as your anchor. And they can talk to the other doctors if there's some that are scary or intimidating or just don't get it. And that's fine too. We don't expect everyone to think the way we are. We are in our speech world and they have a lot of other things going on, but give it a chance. Just because they say no once doesn't mean they're going to say no again. Keep trying. So structure your multidisciplinary rounds. Evidence shows that teams that include SLPs, respiratory therapists, RNs, NPs, those patients, those trachs have shorter length of stay and improved quality of care because they have multiple people rounding on them with one dedicated purpose, which is improving their quality of life and moving them through the system and progressing them accordingly. We want to protocolize those pathways, right? So going back to the readiness criteria, you got to have a flow sheet to describe what is readiness and what you're looking at. And then you want to protocolize those pathways with flexibility. The word protocol scares the heck out of doctors and surgeons because they don't like black and white. And they know that medicine is evolving and it's gray. So when you slap on a protocol that makes them think, oh my gosh, it's going to be yes or no, let them know that there's always room for flexibility. What works on your floor? Do you prefer a trach change at 7 days? That's fine. The lung floor likes to do 10. Give them examples. The floor above you is doing 10 days. What feels comfortable for you? But let's create some sort of guideline so we're all on the same page. So when Dr. Smith is out for his 10-day stretch and Dr. Joe comes in, he can still follow this similar protocol with maybe his own nuances, but we're not all on like alternate planets and we have to wait for Dr. Smith to come back in 2 weeks later to then start the plan over again. Okay. And then, so nothing rigid, right? Make those algorithms nice and flexible. And then finally, education and culture change. So teams are going to succeed when nurses understand speaking valve, when doctors understand speaking valves, when they understand the risk, when they understand that we're not hurting or harming the patient, we're assisting and facilitating communication, swallowing, and airway breathing. When respiratory therapists see us as partners, not as like enemies. Oh God, speech is coming down the hallway. I don't want to do a speaking valve. Teams are successful when families are trained early and they feel confident. When you walk in the room, speech is here, great. We're going to go over suctioning. We're going to work on the speaking valve. We're going to do ice chips. So when the family feels confident and they're not scared to be discharged. Trach teams just don't change the outcomes, but they change culture. So, and this applies to any team, right? But I'm focused on trachs. But when you can create this team that we all have a dedicated passion, a dedicated vision, we're changing the culture, but then we're also changing the outcome. So it's like a double whammy. Okay. So our final thoughts, so we can have some time for questions, is speaking valves don't define readiness, right? We define the readiness, speech language pathologists, in accordance with our team members. It's not just a one-man show, but it's also not just a speaking valve show. It's not the, oh, they didn't tolerate this, then like, please don't try again for a week. Tracheostomy progression is non-linear. It requires consistent and continuous reassessment. Remember that cylindrical reality of the circle. It's not a straight line. Things happen. It's readiness based, so we're going to integrate our airway, our swallow, and our communication readiness domains and utilize all of our tools in our toolbox to help our patient. It's team dependent, right? We want to sustain this through multidisciplinary collaboration. It's not a one-man show. We can't do it alone. We need someone to do the decannulation and the downsizing. We need someone to put the trach. We also need someone to work with us in between on vent weaning and inline speaking valve. We need a radiologist to help us with the video swallow. So it is a multidisciplinary effort. Okay. So when SLPs move beyond a task, like task completion, right? We're very task-oriented people. We're type A. When we move past that completion to readiness-based decision making, that's when tracheostomy care becomes safer, more efficient, and more humane. So stop thinking about checking off your boxes and start thinking about, is the patient ready? And how can I do this? What's my decision-making process? Who am I collaborating with? And how are we going to get it to happen on the next time? Maybe it's not a complete check. Maybe it was a partial. They tolerated cuff deflation. We're going to try speaking valve next session. Oh no, we can't try speaking valve. Let's do a communication board. So just constantly evolving and changing our perspective. Okay. So instead of thinking the patient didn't tolerate the valve, let's think, is my patient airway ready today? Not, is my patient ready to tolerate the valve? Is my patient airway ready today? Okay. So we're thinking about readiness. Thank you for listening. So this is my email. Email me at Trach Talks. I have additional tracheostomy courses available, advanced courses, beginning courses. They're all Zoom recorded, and you'll get PowerPoints for those. But check it out. Check out my Instagram and check out the Badge Buddies. That is there too. So there's a really great bundle on respiratory that comes with about 9 or 10 badges, and it's great to have on your badge and go. So check it out. I hope you guys enjoyed, and these are my references.
Awesome. Thanks, Rachel. We do have a lot of questions. Before
Sure.
we jump in, just a couple of quick housekeeping items. Like I mentioned at the beginning, if you'd like ASHA CEUs for tonight's event, please complete the brief survey that is included in the chat a couple of times and will be sent out via email from Zoom. Oh, Rachel, would you go back a slide so people can screenshot
Yeah.
the references? And
Oh,
then
sorry. Yes.
if you can't access the survey because you're on your iPhone or something, just send us an email at tims-unum@tims.com. Additionally, if you'd like a certificate of completion, please send us an email at that same email address, tims-unum@tims.com, with your first and last name. With that, let's go ahead and dive into as many questions as we can get to. Okay, for your standardized readiness criteria, do you use the graph you showed before or something different?
The graph before is like an image that I don't really flash it to anyone or show it to anyone. That's just like a mindset. But my domains are always going to be airway, swallow, and communication. But you have to keep that cylindrical image in mind because if you're going in this room thinking like one, like a linear, you're gonna be thinking task oriented and complete, complete, complete. And that it doesn't operate like that. It operates in a circle, and your doctors are going to talk to you that way. Your physicians are going to talk to you that way. So it's better for you to understand that it is a cylindrical method and you're going in to assess readiness, not yes or no tolerance.
Awesome. There were a ton of questions about RMST
Mhm.
in the chat and Q&A. So I'm going to ask this one from Stephanie. Can you talk a little bit more about how to use RMST, EMST with patients who have a trach? She said, like literally, how do you do it and where do you place the device?
Okay, so I'm not the expert on this. I do it often, but my colleague does it all the time. And like sometimes I even have to call her and I'm like, oh my gosh, bring the attachment. So she does attach it to when they're in line. I mean, her and I attach it to the T piece. So right where you would attach So there's like where you could do this, it really depends on your T tubing. It's very difficult to explain because a lot of hospitals have different Ballards and T tubes. But if you're going to attach like a speaking valve with a 22 adapter, you're placing it along the side, right? And then you still have more tubing going to your vent. You have an Omniflex or just corrugated tubing, and then you have your filter. We usually attach it right there at the corrugated tubing in line. And that's when it makes like the duck sound. So you have the patient take the big and they do like a quacking noise. Or if you're doing expiratory, you're gonna attach it either directly to hub, but my colleague also does it inline. She's way better at that. And I don't know if I could put a plug. I do think she's taken the other Richards course on EMSC. They had really good information on that. But I don't know if I'm allowed to plug that. But
Yeah,
if you
you
have a
can.
question, you can always email me and I can ask her and she can give me like some step by step. It's just really hard to describe in words. It's more like a visual thing that you have to see.
I'll link the course that Rachel's referring
Yeah,
to in
yeah,
the chat as well.
perfect.
Before I do that, I'll get to our next question. This attendee said, I work in a large academic medical center with 7 different ICUs and several different services that place trachs. We started a trach team last year, but are having trouble getting buy-in from certain teams who prefer to quote unquote manage their own trachs. Any advice on convincing these teams to let us in on helping to manage their patients?
Yep, that's a dying age problem. It's happening right now with me. And for example, ENT manages their own, trauma manages their own, but pulmonary and critical cares are like, hey, do what you want. So just for some clarification on your question, when you mean manage, do you mean allowing the speech pathologist to put like a speaking valve and do dysphagia evaluation, or is it more like allowing the trach team to go in and downsize, decannulate, and cap? Because they're two very, very different things. And I think the best solution to that is like meet them halfway. They may not want to give you full autonomy. And I know a lot of doctors are like that and surgeons, and that's fine. Let them let you do your speech role. And if they need to do their surgical portion, which is the actual downsize of decannulation, so be it. But let them give you a little free range, but maybe not all free range.
Awesome. This one should be a quick one for you. Do you deflate cuffs or do you leave that to the physician or respiratory?
Well, so when it's inline, there's always a respiratory therapist with me. We've gotten Most of them have gotten very comfortable with us, but they're just like in the room, like next to the vent. And what I honestly, whatever side that the cuff is on, they'll like hand me the syringe and we'll do it. But obviously, there's always a respiratory therapist present. The only time I'll deflate cuffs by myself is when they're off the vent and I walk into the room and the cuff's still inflated. But I'll always get clearance from like the nurse or someone on the floor saying, hey, has this patient's been off the vent? Did they just come back from the OR? Like, what's going on? Why is the cuff inflated? Why? Because I've made the mistake and I've deflated a cuff before on my own from a non-vented patient, thinking, oh, this should just be deflated. And that cuff was actually stenting an airway for an ENT patient. So always ask, because they do that on purpose. Like it was a Crike patient and they had a lot of injuries here, so that cuff was serving a purpose, and I went and deflated it. Nothing critical happened. So always ask. You'll always have a respiratory therapist in line with the vent. And if they give you the autonomy to do it, hey, I'll do it with you while you're in the room, whatever, fine, because you have someone supervising. But when alone and it's just a trach collar, always ask, but it should be fine because you're reducing laryngeal trauma, trauma, and laryngeal trauma from that overinflation or the tube being inflated for no reason, serving no purpose.
This person said, would recent trach placement be a contraindication, or is there a certain amount of time post-op you would recommend for EMST given the potential of increased pressures? I always check with the medical team if unsure, but wanted to see your perspective.
Yeah, that's a great question. I will say, like the first day, I mean, it's something we implement a few days down the line. It's not something that we're doing from the get-go. I say that because I don't want to say it's not a priority, but there are other things that I like to address first, right? Like I do want to see airway patency. I do usually get a fees before that, check out the airway. Secretion management, I kind of want to see what's going on in there, see how many times they're being suctioned, what kind of secretions, before we really implement something that is a really therapeutic and very heavy on the physical perspective, right? Some of these patients aren't ready for them because they're so sick and they're so weak that we're not going to get a lot going. So I work on other things like oral care, doing a fees, working on ice chips, working on effortful swallows, working on phonation, and then kind of implement that later. That is something I do down the line. There's not, at least I don't think there's a hard and stop onset date of when you do it. I just wouldn't do it within 24 hours usually. But after that's fair game.
There were a lot of comments and questions about the use of EMST versus breather device. So participants wanted to know if you ever use the breather if EMST is too difficult for a patient.
So we don't have breather at my facility, and I'm not familiar with it in the sense that I really have never used it. I've seen it. We have the EMS, the light version. So because most of our patients are so sick that they need like the lowest type of volume, so or pressure. We don't use the one that has the exponential. I think it's the blue. I'm not even remembering right now. Um, but yeah, if in doubt and your hospital is going to buy one, at least from my perspective, I would buy the light that has less pressure because in an acute setting, those patients are not blowing at the highest pressure. A lot of them are sitting at like 10, 15 centimeters of water for a long time.
And I did put a link in the chat to an awesome resource from Dr. James Curtis talking about pressure threshold devices, which is what the EMST devices are and the breather is not. So there is a difference between the two, not saying which to use or not use, but just for more free information about RMST, that's a great place to start. And I did link Brooke's course about RMST, and I know she dives into all the different available devices on the market. So definitely check those out if you're interested in learning more. And I see Kelly is also mentioning the difference between pressure threshold and devices that aren't. So be sure and check that out in the chat. Let's see, I think we have time maybe for one more question. Let's see. And Rachel, there was a question about your badge buddy.
Mhm.
Some people aren't able to scan the QR code. Do you have a link for that you could put in
Oh, I could. Yeah. Yeah,
the chat?
should I stop sharing to do that? Let me stop sharing. I don't know why that didn't work. Okay,
Yeah,
yeah,
that'd
let
be
me get the
great.
link really quick for you guys. And yeah, I mean, I
Okay,
can
and
have
then
more questions.
um,
You let
this
me know.
um, this question was asked a couple of times, so I'll go ahead and ask this one. How would you justify a fees more so for assessment of decannulation readiness, but the patient may be a Rancho 3 or 4 and orally defensive or not accepting of PO? Do you bill for a fees for trach decannulation readiness even if they aren't swallowing?
Yeah, yeah. So I many times I have to justify or explain why I want to do a fees, and it has really nothing to do with like putting them on a PO diet. And they know that, right? So it's like if the patient is a Ranchos 3, I'm not going to say I'm not going to put anything in their mouth because sometimes you'd be very surprised when you put anything to their mouth. If they're not clenched or biting, they may actually accept trials. And a lot of the times, like the sad part is that patients go home like that and the family ends up feeding them anyways. Like they end up giving them sips of water or whatever. So like why not check and see if they're safe, right? Like it's a controlled environment. You can suction them right after. But a lot of the times I'll just tell the physician, "Hey, I want to do this assessment. It's for airway readiness or decannulation readiness. I want to check out secretion management." And once I just tell them secretion management, they're like, "Oh, great, do it. Like do what you want," because they kind of want to know that too. They want to know like we're the only people who look at that part of the body, right? Like unless they're getting intubated, no one else is looking at the larynx and looking at secretion management. So you're giving them information that they wouldn't have gotten otherwise. You're not putting the patient at harm. It's a controlled environment, and I bill it the same way. It's a fees regardless, whether you're assessing swallowing, whether you're assessing airway or secretions. It's an assessment looking at the larynx, the pharynx. I can put the link in the chat right now for you guys.
Awesome. Thanks, Rachel. This question is, how long are you waiting for, or how long are you waiting on a PMV consult for inline?
The day they get trached. Like since we have so back to the post-op order set, the day they get trached, we should get a consult. We're still working on that. At my last facility, we were up to like 90% of the patients getting consults. Here we're like at 65. But when you get a consult for a trach post-op, our inline or our PMV is embedded in the order. So I don't have to go back and ask for another order. Sometimes I don't get the correct order and then I gotta go back. I know the Passing website says that you shouldn't place a speaking valve from 24 to 48 hours post-op. I do think that a lot of that literature is outdated, especially in a percutaneous trach, which is not an open trach, not done in an OR. A trach done at bedside. Percutaneous trach is just done with dilators. There's minimal blood loss, there's minimal trauma. Those patients, literature has shown, I don't have the exact article on hand, but if you just type in percutaneous trach time to speaking valve, There's a very recent article, 2021, 2022, that you can do it within 24 hours. So depending on your hospital's policy, some say 24, some say 48, but like realistically, you can start an inline as soon as that patient can tolerate a cuff deflation or as the doctor is willing to allow for cuff deflation.
Awesome. I know we did not get to all the questions. We'll do one more before we wrap up. This attendee asked, I've had ICU docs express their questions and concerns with long recruitment issues with inline PMV. I know there's research cited on the PMV website, but how are you providing education regarding this to reassure your medical teams, nursing, respiratory therapy, etc.?
Constant education, constant lectures, constant in-services, webinars. I mean, it's like a broken record. It's very irritating, but no one else is going to do it. So we give in services. We've done like trach education sessions to nursing, to all the staff. We've tried to bring Passimir into the hospital, and they don't seem to be really on board. I don't know if you have to pay for that or if it's free. I don't even remember. But they want everything to be done in-house. So I would say like ramp up a presentation, make a PowerPoint, maybe 10 slides, or even try to do like a lunch and learn or meet them at a huddle and make it like a 10-minute debrief on the benefits of a speaking valve and how to order it, something like that. So, but it's a lot on us, but unfortunately, that's the only way they're going to learn.
Awesome. Well, thank you so much for your time and expertise, Rachel, and thank you all for joining us this evening. Like I said, the survey link will be sent out via Zoom, and if you have any questions or difficulty accessing it, just send us an email at tims@tims.com. If you have questions for Rachel, feel free to reach out to her on social media or via email, and we hope you all have a great rest of your evening. Thanks, everybody.
Thank you so much. Bye, Brooke. Bye,
Bye.
everyone.